Boom.
Woi, mantap. 2 SSD dia laju gila.
Okay, Bismillahirrahmanirrahim.
Alright,
So today I will be explaining about the cerebral edema. Okay, but okay, you guys kena tahu lah, cerebral edema ni dia always secondary, always ada something yang problem and dia akan cause cerebral edema. So dia secondary causes. Contoh for example like a stroke or a brain injury, and then secondary cause memang akan dapat cerebral edema kalau kita tak treat awal lah. Okay, so definition. Also known as brain swelling, it's life-threatening that causes fluid to develop in the brain. Right, so as this fluid increases, the pressure inside the skull will actually increase. Then it is defined also as intracranial pressure. So volume increase, fluid increase, then increase in intracranial pressure. So increased ICP can reduce your brain blood flow because of the brain content you dah volume kan dah besar. You actually will be impede or you akan tekan, okay, you akan pinch on your brain blood flow and decrease the oxygen to your brain receive lah. It can also cause irreversible damage because patient yang cerebral edema lama-lama kita treat dia boleh cause brain herniation. That's what we call irreversible damage because brain herniation we cannot treat anymore. It is irreversible. So pathophysio we have several types of cerebral edema: vasogenic, cytotoxic, institutional, and also ionic. So vasogenic, it is edema that involve the blood-brain barrier. So this BBB is formed by astrocyte, pericytes, endothelial cells. So these cells are actually a supporting cell of the neurons. Okay, beside our neuron, beside our axon, all that. So we have these surrounding cells, astrocyte, pericyte, and also endothelial cell. Okay. So for example, patient yang ada tumor, patient will have locally produced VGF, other leukotrienes. So this tumor will increase permeability, causing disruption of blood-brain barrier. And bila dia ada this disruption, will cause extravasation and accumulation of fluid in the brain. Dia akan keluar. Dia akan mula-mula kan dekat blood kan. So bila kita ada tumor, dia akan impinge the blood. So bila dia impinge the blood, pressure tinggi, and then dia akan cause permeability. So bila permeability keluar, dia akan cause extracellular brain edema, which is surrounding site tu akan jadi swelling, like astrocyte swelling, glial cell will be swelling, so causes vasogenic edema. So korang ingatlah vasogenic edema ni luar daripada blood vessel, so dia extracellular. So there are several condition, for example like CNS.
Hello?
Hello.
Dan.
Member okay tak?
SSD. Hello?
Dan.
Mana SSD kita ni?
Saya Dan.
Oh, dia tengah lagging.
Lagging ah?
Oh, saya tak tahu dia pakai wifi card saya ke tak tahu je. Mesej dia.
Dan.
Oh, saya mesej dah.
Alright. Saya nyanyi dulu sambil tu boleh?
Boleh.
Suhal okey tak Suhal? Member senyap lah.
Member.
Beres.
Suai, kita tengok je Dan tu. Aku dah cakap kat dia.
Apa Dan?
Tengok je apa cerita laptop dia.
Dia berak.
Takut dia tengah present.
Oh ya, dia pergi.
Aku pergi kah? Saya takut dia pakai wifi sebab dia ada 2 wifi sekarang. Sekejap.
Okay.
Alright, let's go.
Edema.
Sorry, okay, right.
So vasogenic edema ni dia akan cause extracellular brain edema caused by increase in permeability. Macam aku cakap tadi, dia ada tumor, okay, locally produced VGF, glutamate. So dia akan cause bila dia impinge the blood and dia akan swelling, dia akan cause extravasation, increase permeability, causing disruption of BBB. So dia akan fluid ni akan accumulate dekat extracellular space, causing vasogenic edema. So korang kena ingat vasogenic edema ni adalah extracellular space punya edema lah. Okay, causes like brain hemorrhage, CNS tumor, diabetes, radiation injury, and also hypertensive encephalopathy. Okay, cytotoxic edema ni common juga, usually happens in ischemia. Sebab apa? Sebab in cytotoxic edema, BBB will remain intact. Sebab tapi in vasogenic edema, BBB will remain disrupted. But cytotoxic edema ni causing due to decreased blood flow and glucose supply. Dia tak ada kena-mena dengan increased permeability. Okay, dia due to decreased blood flow and also glucose supply causing ischemia. So bila ada benda tu, dia akan impact sodium and potassium pump, causing retention of sodium ions and rapid uptake of water through osmosis. Sekejap. Okay. And then rapid uptake of water through osmosis causing swelling of the cell. Sebab sodium dah masuk dekat sel, water dah masuk dekat sel. Yeah, so causing cytotoxic edema lah, swelling of the cells. So dia ada banyak clinical condition. For example, the common one is caused by traumatic brain injury. The early phase of ischemic stroke. Mula-mula memang kita sudah dapat bila ada ischemia akan cause cytotoxic edema. Dia bukan hemorrhagic. Dia bukan vasogenic. Okay. So ingat kalau ischemia je kita akan cause cytotoxic edema. Alright, toxic exposure, hypoxia semua tu. Okay, these are the pathophysiology in visual lah. So contoh nampak tu kalau dalam vasogenic edema tu blood-brain barrier kan forming, BBB ada. But then still ada extravasation. Korang dengar kan?
Dengar.
Alright. So vasogenic edema
Sorry. Saya cakap tadi.
extravasation of fluid and serum protein by BBB disruption. Macam aku cakap tadi, dia ada disruption of the BBB. So dia akan cause increase permeability. So semua fluid dalam tu akan keluar. Right. So macam tu. So for cytotoxic edema pula, patient tak ada BBB. Dia remain intact. Tapi due to oxidative stress, due to ischemia, patient ada ATP deficient, so dia akan cause sodium and potassium ion punya disruption lah. So bila ada disruption tu, sodium and water akan masuk dalam cell and causing a cell punya edema. That's why dapat tu outflow of intravascular. Dia akan keluar tapi dia masuk kat cell dia surrounding. So causing cytotoxic edema. Interstitial edema pula is seen in hydrocephalus. So korang ingat interstitial edema ni is related to CSF. Okay, cerebrospinal fluid due to obstruction. So the result is movement of sodium and water across the ventricular wall into the periventricular wall. So you guys know that CSF is actually originated from ventricles kan. So from this ventricle, due to in hydrocephalus, you will be the ventricle will be obstructed. So when the ventricle is obstructed, you will cause the movement of sodium and water to move from the ventricular wall into the peri. Dia akan keluar. So causing interstitial cerebral edema due to obstruction of normal CSF pathway. Contoh for example like this one, ni normal pathway. Contoh dia from lateral ventricle, then pergi third ventricle, and then pergi fourth ventricle, subarachnoid space, and also to the venous blood lah. So for example kalau contoh patient ada obstruction dekat, dia ada hydrocephalus kan. Okay, and then dia ada obstruction dekat contohlah fourth ventricle. Fourth ventricle dia obstructed. So bila ada obstruction, semua fluid dalam ventricular wall tu akan pecah, causing all the fluid tu akan pergi dekat surrounding periventricular wall, causing banyak fluid accumulate, causing hydrocephalus lah. So that's the thing. So sebab hydrocephalus is due to Arnold Chiari malformation kan, yang belakang tu. So cerebellum akan jadi jatuh. So bila jatuh dia akan jadi obstructed. Bila obstructed, dia tak boleh nak flow. Macam tadi lah, ada pathophysiology yang dia tak boleh nak, dia from ventricular wall dia akan pecah through periventricular wall. So causing fluid banyak, jadilah kepala besar, jadi hydrocephalus. So this is ionic edema. Ionic edema ni it is when solid concentration of the brain exceeds that of the plasma, and the abnormal pressure gradient leads to accumulation of water and also sodium lah, because of the solute and intake into the brain parenchyma through the process of osmosis. Macam tadi juga, macam cytotoxic juga. Okay, the blood barrier is intact and then just the solid concentration to exceeds. Okay. So etiology dia ischemic stroke, brain tumor, intracerebral hemorrhage. Okay. So progression of brain swelling. usually normal anatomy nampak skull kat luar kan. Ventricles pun tak ada dilated sangat. Okay, you have generous space within the brain. But then when the patient ada mild cerebral edema, when you have accumulation of fluid, okay, disruption of BBB, you will cause increase in volume of the brain content, so causing diffuse swelling with brain tissue pressed up against the wall of skull. Okay, and then the last one, moderate cerebral edema, patient will have slit-like appearance of ventricles. Ventricle tu nampak terlalu kecil, jadi macam like a narrow punya space je. So this causing compression of cerebral ventricles. Okay, pathophysio ni I can say sama je macam tadi. Okay, so clinical sign of cerebral edema and brain, kita tak touch brain herniation, kita touch cerebral edema lah, right? So cerebral edema ni alone will not produce clinical neurological abnormalities unless the ICP reaches a level that produce local ischemia. Nampak? Usually, nampak bawah punya statement, there will always be the primary underlying condition. Cerebral edema will add on or complicate the clinical features of the underlying condition. So macam aku cakap tadi, dia memang secondary. Dia ada underlying causes, stroke ke, traumatic brain injury, baru dia dapat cerebral edema. Tak ada patient yang tiba-tiba dapat cerebral edema. Dia always ada primary punya causes. Okay, so right ni, okay, depan ni aku akan explain depan ni. Okay, symptom of cerebral edema. Okay, patient will have flattened gyri kan, sebab ni lah, kita ada kan gyri and sulcus kan. So this gyri akan flatten, sulcus akan jadi narrow due to extravasation of fluid and accumulation of fluid. So lama-lama dia bengkak and ada edema, ada narrow sulcus lah. Okay, enlarged ventricles, enlarged head size. Okay, ini in terms of hydrocephalus lah. And also mass effect will cause brain herniation. Sebab dia terlalu besar, bila terlalu besar and then dia boleh cause central herniation. Selalunya central lah kalau yang besar, terlalu besar sangat. Kalau macam epidural hematoma or subdural hematoma will cause subtentorial, dia akan uncle herniation, dia akan pergi yang belah kiri tu nanti lah, itu herniation lah. Okay, sign symptom for cerebral edema ni hyperventilation, okay, increased muscle tone, dilated pupil. Dilated pupil ni is mostly due to oculomotor nerve palsy lah. Okay, sebab obviously the oculomotor nerve palsy is located at brainstem. So bila you have enlargement of the brain, it directly you will cause compression juga dekat brainstem kan. So boleh dapat lah oculomotor nerve palsy. And then increased ICP sign will have crushing triad, reduced LOC, loss of consciousness, and focal neuroscience. Okay, ni DKA tak apa. Okay, ni 5 sign is to be highly suspicious. So number 1 is altered level of consciousness. So usually patient yang datang with brain injury lah, contoh brain injury, dia macam tak ada consciousness, dia altered level. So kita suspect patient ada dah ada cerebral edema. So macam mana kita nak confirm patient ada altered level of consciousness is kita pakai GCS lah. Okay, Glasgow Coma Scale. Sebab Glasgow Coma Scale ni is the gold standard or the main standard lah sekarang ni. Kita pakai GCS untuk check any patient with impaired consciousness, either acute medical causes ataupun trauma causes. Contoh in patient ischemia, ischemic stroke. So patient ischemic stroke memang dia ada weakness, tapi if severity dia boleh cause altered level consciousness juga. So kita kena buat GCS juga. Any patient yang ada impact consciousness, kita buat GCS. Okay, so tapi ada juga problem dengan GCS ni. Pre-existing factors due to language barrier. Kalau patient tu tiba datang dengan Thailand, kita nak cakap tak tahu kan. So intellectual or neurological deficit, patient yang ada ID, intellectual disability, so tak boleh nak cakap sangat. So hearing loss or speech impediment. So these are the factor yang boleh cause Glasgow Coma Scale punya assessment. Effect of current treatment, contoh physical intubation. Intubation kita tak boleh buat sebab one of the criteria dalam GCS kena ada verbal response. So if patient on intubate in ET, endotracheal intubation, macam mana dia nak cakap? Betul tak? So tak boleh pakai GCS dalam intubation. So pharmacological like sedation or paralysis tak boleh juga lah, sebab paralysis sebab GCS dia akan assess juga motor response. So if patient with paralysis, kita tak boleh nak assess GCS. Ataupun sedation, dia tengah tidur, eye motor response pun tak ada, verbal response pun tak ada, so tak boleh buat patient with GCS. That's why if possible, clinician should obtain the score before sedating the patient lah. Okay, ni 4 score. 4 score ni is relevant if patient intubated ataupun in awake patient, sebab dia tak ada verbal response punya assessment. Dia ada eye response, dia ada motor response, brainstem reflexes and respiration. Okay. Before that, nak cakap korang ni apa, sorry, DCS ni dia ada scale dia, nampak? Totally unresponsive 3, dia paling teruk 3 lah. Coma client 8 or less, ataupun best response is 15 lah. Okay. Ni korang kena hafal lah, sebab maybe it very important lah in neuro. So korang kena hafal ni. For score pun I think bagus lah kalau kau hafal. Okay. So question triad is a late sign of ICP. Okay. ICP, increase intracranial pressure. Okay, mula-mula ICP mungkin kita dapat headache kan, headache, nausea, vomiting, tapi lama-lama dia akan dapat this triad: hypertension, bradycardia, and also abnormal breathing pattern. Okay, kenapa? Okay, cushion reflex ni, ada some researcher cakap he believed that the dramatic increase in blood pressure was a reflex to brainstem ischemia. Okay, seen in patient with increasing ICP. So patient yang ada increased ICP, usually yang macam intracranial hemorrhage ni semua, dia akan cause dia akan cause increase in blood pressure. So bila ada increase in blood pressure, so bila dia increase blood pressure and also dia ada mass kan, increase mass ni, dia akan impinge the brainstem. So any blood vessel yang go to the brainstem will be obstructed lah. Sebab dia dah besar, dia impinge the brainstem, jadi ischemia brainstem tu. So in the first stage, blood pressure and heart rate rise in response to systemic activation to overcome the ICP. That's why patient ada hypertension. That's why blood pressure dia tinggi, that's why heart rate dia tinggi in response to sympathetic activation to overcome increased ICP. So this explain how patient ada hypertension. In the second stage, hypertension continue to be present, but patient tak ada tachycardic, tapi dia jadi bradycardia. That's why in one of the triad of the cohesion triad, dia ada bradycardia. Sebab apa? It's due to result from compression of the intracranial vagal nerve. I'm not sure what is this, but dia cakap compression of the intracranial vagus nerve kita. So bila kita ada compression of vagus nerve, so kita boleh cause bradycardia. How? I think you kena baca about the vagus nerve thing. Okay. So ini explain why patient ada bradycardia.
Bismillah.
In the latest stage of the cushion reflex, brainstem dysfunction. Sebab aku cakap tadi, bila besar-besar ICP tinggi and all that kan, brainstem will be infarcted, ischemic, so brainstem dysfunction causing irregularity in breathing. Sebab you all kena tahu brainstem ada function in breathing. Okay, dia ada chemoreceptor of regulator lah situ. So will cause irregularity in breathing. So 3 is evidence of extraocular. So these are the one of the signs juga patient ada cerebral edema.
Dan, sorry.
Yo.
Soalan sikit.
Okay.
So tadi, based on tadi yang Cushing reflex ni, kalau patient datang emergency with ready dengan increase in blood pressure, maknanya you need to suspect they having Cushing reflex ke?
Cushing reflex, yes.
So kita takut dia ada apa-apalah, edema,
Sebab dia paling
internal cranial hemorrhage.
paling kita takut is brainstem ischemia. Sebab dia dapat breathing, irregular in breathing. So bila irregular breathing, kadang-kadang patient boleh dapat apnea. Dia tak ada bernafas. So tu bahaya.
Okay. So usually kalau high blood pressure, dia techy ke? Kenapa?
That's why Brady sebab ni, nampak? Actually result
Compression
from
vagus
compression
nerve.
vagal. Tapi kau kena, aku tak sure lah, tapi kau kena baca about intracranial vagal nerve. Mungkin sebab kita tahu vagus nerve is macam dia responsible for sympathetic nerve kan.
Sympathetic.
So bila sympathetic
Dia bagi jadi Brady lah.
Jadi Brady lah.
Tapi kalau compress, bukan dia akan jadi less activated.
No. Dia function vagal nerve sympathetic kan. Tapi bila compress the vagal nerve, jadi Brady lah. So dia jadi sympathetic lah. So dia jadi more
vagal bukan parasympathetic, dia sympathetic.
So oppose the action lah.
Okay. Alright, thanks.
Okay, nombor 3, alteration and inequality of pupillary size, third nerve palsy. Ni pun disebabkan of the brainstem punya ischemia. So lama-lama dia increase mass, all that kan. So dia akan cause third nerve palsy ataupun due to brain herniation. In uncle herniation pun boleh cause third nerve palsy lah. So kita tak sure, that's why kita buat investigation lah. Okay. Benda ni tak ya. Okay, extensive plantar response on the side of the lesion, UMN lesion. Sebab cerebral edema kan, kita boleh suspect.
Dan just buat restart tonight tu supaya dia tak
Okay.
kacau. Alright, thanks.
So extensive plantar response on the side of lesion. UM lesion ni kita tengok apa? Babinski lah. Okay, Babinski. Kita if suspect UM lesion. So other clinical manifestation, headache, nausea, vomiting, alter cognition, focal deficit. So this is ada ICP punya symptoms, other ICP symptoms. Okay. The most common cause of neural okay, nampak. The most common cause of neural deterioration and death during acute ischemic stroke yang Syafiq akan present nanti is cerebral edema. So lama-lama memang ada ischemia, tapi bila dia dah lama sangat kita tak bagi thrombolysis, kita tak bagi any medication pun, tak bagi RT apa benda nama RTPA, okay. Dia akan peaks at 24 to 96 hours. So patient will get cerebral edema. So usually confined to ischemic region, tapi lama-lama dia akan cause diffuse cerebral edema. Alright, so this is Monroe-Kelly hypothesis. Okay, macam ni contoh dia. Dia punya pathophysiology is, contoh volume of brain kita is 1400 ml and CSF kita 150 ml and other blood is 150 ml. So nampak, since skull is a rigid box that cannot be stretched, if the volume of one of these components is increased, so there will be compensatory reduction. For example, patient yang ada contoh dia ada contoh volume of brain dia makin increase kan, increase, CSF akan jadi reduce lah. Sebab dia cakap compensatory reduction of volume of the other component. So yang contoh volume of brain tinggi, lama-lama CSF akan rendah, blood akan rendah. So any rise in ICP is limited to some extent by the compensatory decreasement of CSF and changes in CBV. Okay, when it override the compensatory mechanism, certain part will start to herniate sebab dia tak boleh nak compensate dah. So jadi lama-lama ICP mass tu akan override the compensatory mechanism. So ICP mass ni akan cause herniation. Lama-lama dia akan jadi herniate juga. Okay. So ni contohlah visual. Contoh CSF nampak 150, blood volume 150, brain kerama volume is 1400. So for example, patient ada intracranial pathology, tumor kan dekat depan tu. Brain parenchyma volume is still okay, tapi compensation lah sebab ada tumor kat situ. So compensation is by increase CSF drainage, dilajukan drainage tu. And then venous drainage pun lajukan sebab ada intracranial pathology. Tapi bila dah lama sangat increasing in size, there will be no further compensatory mechanism. Dia macam exhausted lah. You dah drain banyak sangat CSF, you dah drain banyak sangat blood, and then increase mass is still increasing. So if you cannot treat the mass, you will get this lah. Patient lama-lama akan jadi herniated lah. So kalau if you treat this early, then the compensatory mechanism still ada lah. Okay, right, that's it lah for me. Faham guys?
Tak, sis. Nice. Okay.
Ya, macam okay.
So yang sampai situ ya hang present.
Itu je lah.
Apa benda yang skip lah?
Herniation ni, yang ni. Herniation ni aku sambung sebab dia banyak.
Banyak, let luar.
Okay.
Alright.
Right. Stroke.
Alright.
Macam nak
Tekan stop streaming, yes.
change windows. Okay, nice.
Alright. Boom, let's go, Syafiq.
Okay.
Syafiq, I just found out that I can record full screen if saya start record waktu dia tengah full screen.
Oh ya ke?
Tadi saya testing. Quite weird, but yeah.
Okay. Tapi
Tak. Okay.
Okay.
Alright, Syafiq, let's go.
Okay, kejap Umar nak join tak? Saya baru nak start.
Apa that? Jakum Banyo.
Stroke. Tak? Okay. Cakemanya. Okay, kejap macam mana buat. Nanti screen.
Oh, ya.
Boom. Go live. Boom. Alright. Welcome to my streaming. Voice. Alright, nampak lah semua?
Nampak.
Boom. Alright, bismillah. Okay, hari ni saya akan present tentang stroke. Okay. Alright. Ni yang kita akan tengok blood sikit lah pasal blood supply of brain, tapi anatomy ni mostly hampa kena baca sendiri lah. Tapi macam saya akan highlight yang mana saya rasa perlu. Lepas tu definition, classification and risk factor of stroke. Lepas tu physio, correlation, investigation and treatment. Boom. Alright. Ni pakai CPG 2012. Sebenarnya ni dah kalau ikut Prof Jeff dah outdated dah berapa. Alright, blood supply. Okay, kita ada internal carotid artery, vertebral artery dan basilar artery. Okay, yang ni yang akan supply the brain. Okay, internal carotid artery, branchia kita ada cranial, cavernous, petrous dan cervical. Cervical dan petrous ni let lu, tak penting. Kita cavernous dan cranial. Vertebral, okay, kita ada anterior spinal, posterior, semua ni lah. Basilar pun ada semua ni. Alright, kita tengok Alright, internal carotid artery. Ini dia punya cause of internal carotid artery. First dia akan lalu dekat tepi ni, dekat the apa ni, C6 sampai C1 punya transverse foramina. Tak apa, dia masuk, just tahu dia masuk dekat dekat foramen lacerum. Lepas tu dia masuk, masuk naik atas, lepas tu dia akan lepas daripada apa nama tempat ni, apa yang berlubang. Dia masuk kat carotid sinus dulu. Ni carotid sinus. Lepas tu dia masuk ni, tak apa, ni tak perlu tahu sangat kot. Alright. Okay, branches of ICA yang dua yang kita kata penting kan, cranial portion, cavernous kan, yang bawah yang semua tu tak perlu. Okay, cranial portion kita ada 5 branch: ophthalmic, posterior communicating, anterior choroidal, anterior cerebral, middle cerebral. Cavernous ada ni, okay. Tapi cavernous tak apa penting sangat sebenarnya. Ni paling penting lah. Alright. Boom. First, okay, ophthalmic daripada cranial portion. Ni kita pergi cranial portion dulu. Ophthalmic artery, dia arise from ICA. Okay, ni internal carotid artery. Dia sini. Dia sini. Mana yang ni? Yang ni ya. Yang ni kot. Yang ni ya. Yang ni kot. Okay. Okay, dia supply the optic nerve lah, optic canal, optic nerve, eyeball, semua ni, semua kat depan. Scalp, sinus, nose, okay. Lepas tu kita ada posterior communicating, yang ni, this one. Okay, kenapa communicating? Sebab ni ICA kan, yang ni posterior cerebral artery, yang ni posterior communicating, dia communicate posterior cerebral dengan ICA. So posterior communicating lah. Okay, dia above the, okay, supplies kawasan dekat kat sini tak perlu tahu. Okay, next kita ada anterior choroidal kat sini. Okay, ni posterior communicating, ni ophthalmic, ni bukan ophthalmic, ni anterior communicating ni. Tak, ni anterior, tak apa, kita tengok nanti. Okay, choroidal yang ni, okay, dia supply the lateral ventricle, crus cerebri, lateral geniculate, optic tract, internal capsule, semua yang dekat sini lah. Okay, bantai kalau okay, what's the supply of this? Just bantai semua yang delicate structures kat sini. Alright. Next is anterior cerebral, which is this one. Okay, this one yang besar ni. Yang ni anterior cerebral, dia enters the longitudinal fissure. Ni fissure, dia enter masuk. Nampak fissure ni kan, ni this fissure kan. Lepas tu join to the opposite side by anterior communicating. Okay, anterior communicating yang join antara anterior dan anterior ni anterior communicating. Alright. Ni okay, curve backward over the corpus callosum. Ni corpus callosum kan, ni this one, the big white one ni, dia curve. Boop. Macam ni. Right. Dan dia ada cortical and central branch. Cortical is the cortex, dia kita supply kat sini. Kan dia dalam fissure kan. Fissure, so dia supply yang semua ni sampai foot. Lepas tu narrow strip dekat sini sampai lebih kurang macam ni lah. Okay. Alright. Central branch yang semua tu lentiform nucleus, caudate nucleus, internal capsule. Okay, all motor area at the precentral gyrus is supplied by medial cerebral artery except leg. Leg saja yang anterior. Okay. Ni medial cerebral. Okay, sorry. Ni anterior. Okay, medial cerebral dekat sini. Okay. Sorry. Medial cerebral dia yang anterior kat sini kan. Nampak ni. This is all anterior. Medial cerebral semua kat sini. Okay. Right. Inferolateral. Inferolateral surface sampai ke occipital pole. Okay. Sini lah sini. Semua ni is MCA. Anterior semua kat sini. Okay. Boom. Alright, ni cavernous portion boleh lah baca. Tak ya. Okay, vertebral. Vertebral dia naik. Okay, dia supply anterior spinal, posterior spinal, supply the spinal cord lah. Lepas tu kita dah meningeal branch. Ni, dia naik kan. Pup. Dia meningeal branch. Dia ada posterior cerebellar. Posterior inferior cerebellar. Pica. Ni, dia cerebellum, supply the inferior part of cerebellum. Kita dah medullary. Medullary medullary somewhere. Dan meningeal branch ni. Alright. Okay. So vertebral artery ada dua kan, from left dengan from right. Dia akan form basilar artery. Okay, ni vertebral. Okay, yang ni yang semua branch tu. Okay, dia akan form basilar artery. Basilar artery kita ada ICA, anterior inferior cerebellar. Okay, tadi posterior inferior cerebellar, ni anterior inferior cerebellar. Lepas tu kita ada labyrinthine, kita ada pontine, but ni pons kan, dia pontine. Lepas tu dia ada posterior cerebral. Okay, ni posterior cerebral. Dia betul superior cerebellar. Okay, kita ada anterior inferior cerebellar, kita ada superior cerebellar. Okay, blah 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 semua. Alright, ni lah. Nanti boleh tengok lah. This is the anterior artery. This is the middle cerebral artery. Ni from the side ni dari dalam. Okay, ni adalah posterior cerebral from the basilar artery. Okay, boom. Right, circle of Willis made of anterior communicating, anterior cerebral artery semua ni, internal carotid, posterior communicating, posterior dan basilar artery. Okay, ni kena tahu. Right, drainage, ni je hafal lah. Ada semua sinus ni. Dia drain to what? Transverse, straight sinus, sigmoid sinus. Okay, blah 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 blah. Okay, alright. Okay, kita masuk ke stroke. What is stroke? Stroke is a clinical syndrome characterized by rapidly developing clinical symptoms and all signs of focal and at times global loss of cerebral function, with symptom lasting more than 24 hours or leading to death, with no apparent cause other than that of vascular. Okay, so daripada ni kita tahu dia adalah syndrome rapid more than 24 hours. Sebab kalau less than 24 hours kita panggil TIA, transient ischemic stroke. Okay, kalau more baru kita panggil stroke. Dan dia mesti kena vascular. Kalau other types macam infection ke ataupun bla bla benda lah, tumor ke kan, dia bukan stroke. Stroke is mesti vascular origin, sama ada ischemic atau hemorrhage. Okay, risk factor, age, age orang tua, gender male more, race don't know, family history of stroke, of course, previous stroke. Modifiable ni lah yang the hypertension, cigarette, sebab cigarette can cause damage to the blood vessel, arteriosclerosis, diabetes sama-sama, atrial fibrillation. Okay, kenapa atrial fibrillation? Sebab dia menyebabkan emboli. Okay, atrial fibrillation boleh menyebabkan emboli. Ini masuk OSCE kita kan hari tu. Coronary heart disease sama dengan ni, hyperlipidemia, obesity, blah 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 blah. Okay, boom. Pathophysiology of stroke, kita ada ischemic, which is most common, hemorrhagic less common. Ischemic thrombosis, okay, macam atherosclerosis ke apa ke. Embolism, contoh atrial fibrillation. Embolism daripada heart tu dia pergi book naik masuk brain. Atau systemic hypoperfusion macam cardiac death ataupun cardiac shock, apa, cardiogenic shock. Okay, cardiogenic shock maksudnya heart tu ada problem, tak boleh nak pump, so there's no perfusion to the brain. Okay, hemorrhage is intracerebral dan subarachnoid. Okay, first is ischemic thrombosis. Thrombosis, atherosclerosis, vasoconstriction, dissection. Okay, anything Alright. Okay, kita ada lacuna infarct, a small non-cortical infarct caused by occlusion of single penetrating branch of the cerebral artery. Penetrating branch macam yang kecil-kecil tu. Yang kejap. Mana? Macam ni lah. Macam penetrating branch ni. Mana? Ni. Penetrating branch. Okay, tu lacuna infarct. Okay, ischemic stroke boleh disebabkan oleh embolism, semua saya cakap tu lah. Atrial fibrillation, valvular heart disease macam infective endocarditis, okay, whatever. Lepas tu systemic hypoperfusion, cardiac pump failure, cardiac arrest, arrhythmia, MI, bla bla bla. Okay. Okay, hypertension. Okay, tak apa. Alright, hemorrhagic stroke, most common is hypertension. Okay, uncontrolled hypertension lah. Lepas tu trauma, bleeding diastasis, bleeding tendency, okay, atau vascular malformation. Okay, symptoms develop gradually over minutes or few hours, not abruptly like embolism or subarachnoid hemorrhage. Okay, embolism ni paling cepat lah sebab dia embolai kan, tiba-tiba pergi dia stuck mana. Okay, tapi kalau hemorrhage dia slow sikit. Tak nak slow macam ischemic yang thrombosis semua ni, tapi dia slow daripada embolai. Right, subarachnoid space is macam saya present itu, yang headache tu. Rupture of berry aneurysm, most common. The berry aneurysm somewhere dekat circle of Willis lah, most common dia tempat. Abrupt worst headache of my life. Okay, dan sign of increased ICP ya. Okay, alright, ni the cause of stroke kita ischemic, hemorrhagic ni hemorrhagic ni increased cerebral ischemic kita dah ni, embolism, hypoperfusion. Okay, penetrating artery disease, lacuna infarct. Okay, ni boleh baca sama ni, kita semua kita tahu ni. Alright, hemorrhagic pathogen kita tahu. Alright, ni berry aneurysm, rupture blood, dia akan rupture blood vessel, accumulate, lepas tu increase ICP, lepas tu sama macam Dan present tadi ya. Okay, correlation between the clinical features of stroke with likely vascular structure involved. Okay, ni kira macam kita based on history or kita punya clinical judgement, kita boleh macam identify lah which part of the brain yang involved, which vessel, which artery yang involved. Okay, contoh kalau anterior and posterior circulation. Okay, usually posterior circulation ni macam cerebella dengan part-part the posterior hemisphere, macam occipital hemisphere semua tu. Anterior yang semua kat depan tu lah. Okay, so kalau anterior, headache, aphasia, hemi or monoparesis. Okay, that's. Kalau posterior, sebab posterior kan ada eye, ada vision punya tu kan, so vision boleh akan affected. Vertigo sebab cerebella kan, drop attack, blah blah blah. Alright, anterior artery circulation. Okay, anterior. Contralateral paralysis and sensory loss affecting lower limb more than upper limb or face, sebab anterior ni kan saya cakap boleh anything lah, tapi dia usually anterior cerebral artery. Dan tengok dia supply kat mana, dia supply kat sini kan. So yang ni je lah yang affected. Leg biasanya, genital leg more than face. Boleh ke kat sini, tapi usually kat sini. Ebulia tu macam patient tak boleh nak make any decision, macam tak boleh nak think lah, sebab semua ni a part of the kita punya intelligence, kita punya decision making semua kat anterior kan. Alright, boom. Middle cerebral artery infarction. Okay, sini supervision. Tengok kat mana dia supply, kita boleh tahu hemiparesis kat sini lah. Ni leg kan, face. Okay, tengok kat mana Broca aphasia. Broca somewhere kat sini. Sini. Ni Broca, tapi dia dekat belah dominant hemisphere. Kalau contoh kalau orang tu right handed, kira left hemisphere. Kalau orang tu left handed, right hemisphere. Okay, inferior je ni. Inferior, but middle cerebral artery dia lalu sini kan, so dia supply this whole part. Okay, so sini hearing. Okay, bla semua ni. Alright. Internal carotid artery. Dia jadi kat internal carotid artery dekat sini. Ada blockage ke, emboli ke apa. Dia variable. Okay, symptomatic occlusions result in a syndrome similar to that of middle cerebral or anterior cerebral or both stroke. Okay, monocular blindness is also common. Okay, blindness lah, sebab kita punya auditory, kita punya optic pathway semua hancur. Okay, posterior artery tadi anterior circulation, ni posterior circulation. Okay, posterior circulation usually the oculomotor, sebab dia akan supply the cerebellum. Lepas tu macam semua structure dekat situ. Okay, oculomotor nerve. Okay, lepas tu dekat occipital punya lobe. Okay, occipital kan kita ada Broadman 17, iaitu untuk visual kan. Okay, so ada visual agnosia, cortical blindness. Okay, semua ni. Alright. Okay, kalau cerebellum, kita tremor, ataxia, dysarthria, diplopia. Kalau kena kat brainstem, yang ni cranial nerve palsy, loss of impairment of consciousness. Usually kalau brainstem, consciousness akan hilang. Okay, tu yang kalau posterior artery infarction, dia impairment of consciousness dia lagi common daripada anterior. Okay, ni adalah sejenis baru. Lacuna infarct. Lacuna infarct is small vessel occlusion dekat penetrating arteries deep in the brain that may infarct the putamen, or less common the thalamus, caudate nucleus, pons, semua ni lah. Right. Semua yang structure saya cakap yang dalam-dalam. Okay, kita ada pure motor, kita ada ataxic hemiparesis, pure sensory stroke, dysarthria, clumsy hand syndrome. Ni tak sure kita perlu tahu tak. Alright. Summary: anterior affected frontal lobe, motor sensory, semua ni. Middle, lateral surface, speech, optic, radiation, parietal lobe, boom, semua tu. Posterior cerebral, occipital lobe. Okay, vertebral basilar, dia rasa macam near sekali. Cerebellum, brainstem. Okay, investigation of stroke, kita tengok pada ischemic dulu. Ischemic stroke, first kita kena buat full blood count lah, sebab ischemia, so mesti ada thrombosis ataupun apalah. Okay, kita tengok polycythemia, anemia from hemoglobinopathy or suggestion concomitant infection. Okay, sebab bila ada infection boleh menyebabkan emboli. Contoh macam saya cakap tadi yang infective endocarditis, semua tu. Random blood glucose, tengok hypoglycemia or hyperglycemia, sebab kalau patient kata dia datang weakness kan, ni kita belajar FMAC juga. Kalau patient tu ada weakness, tak semestinya stroke. Okay, dia mungkin hypo. Okay, so kita test blood glucose. Kalau blood glucose okay, baru kita cakap okay, ni patient ni maybe ada stroke. So kalau blood glucose barai, memang maybe is just hypoglycemia, bukan stroke pun. Okay, kita buat urea electrolyte, tengok hydration, exclude imbalances. Kalau patient ada focal neurological signs, kan kalau stroke boleh ada patient ada hemiparesis, ada apa-apa lah, seizure pun boleh. So kita tengok kita urea electrolyte, kuat electrolyte imbalance yang menyebabkan tu clotting profile. Next day kita buat kita check the lipid, the blood glucose, tengok patient punya risk factor. Okay. Alright, so dia cakap patient yang selalu ada TIA, transient ischemic attack, which is weakness or anything, focal neurological sign less than 24 hours, should be screened for diabetes mellitus by measuring. Okay, nampak? Maksudnya dia bercakap diabetes punya risk factor untuk ni memang tinggi lah. Okay, next optional ni depend on history. Kalau kita suspect patient ni okay, dia ada neurosyphilis. Kan syphilis kita ada syphilis, primary syphilis, secondary syphilis, kita juga ada neurosyphilis kan. Neurosyphilis basically dia attack the brain lah. Okay, which suggest syphilitic arthritis. Dia boleh. Okay, tapi depend on the kita punya history. Okay, autoimmune boleh jadi. Ada investigation, kita kena buat ECG sebab boleh atrial fibrillation. Okay, atrial fibrillation menyebabkan embolism. Okay, imaging, chest x-ray mandatory. Sebab apa saya tak sure. Siapa tahu sebab apa, saya tak sure lah. Okay, tapi most important is CT brain. Okay, CT brain sebab kita nak tengok, kita boleh tahu sebenarnya is ischemia or is hemorrhage. Okay. Okay, traumas. Okay, kalau earlier CT scan hyperdense vessel. Alright, boom. Kalau dah lama sikit, dia jadi gini, hypodense. Alright, insert patient echo. Kalau kita suspect ni MRI, CT. Okay, right ni. Okay, ni kalau tadi ischemic stroke. Okay, ni hemorrhagic stroke. Still akan buat CT brain, nak tengok dia akan hyperdense lesion. Macam ni, boom. Okay, sebab dia blood kan, water. Alright, angiografi boleh buat kalau kita suspect patient ada aneurysm or arteriovenous malformation, angiograph. Betul, kita buat full blood count, tengok patient ada any bleeding diastasis lah, bleeding tendency, clotting sama. Lepas tu chemistry panel kita buat tu, check glucose kan, sebab tengok akan patient sebenarnya hypoglycemia ke memang stroke. Lepas tu electrolyte imbalance ke apa. Okay, sama juga tadi. Right, cuma beza yang ni kena tahu. This is ischemic, this is hemorrhagic. Hemorrhagic is hyperdense, ischemic is hypodense. In CT scan. Right, boom, treatment. Alright, treatment. Okay, okay, treatment. Okay, system of sign suggestive stroke. Okay, persist more than 1 hour. Acute care, urgent clinical evaluation. Kita kena buat CT scan. Okay, memang kena buat CT scan sebab kita nak tahu hemorrhagic ke ischemic, sebab dia punya treatment different. Kalau ischemic kita boleh buat thrombolytic therapy, nak cuba lyse the thrombus. Kalau hemorrhage kita mungkin kena buat surgical decompression ke, ataupun kalau aneurysm ya pecah, barrier aneurysm pecah, kita kena buat clipping dekat artery tu ke. Okay, kita buat blood test ECG lah, macam cakap tadi. Kalau ischemic stroke boleh buat thrombolytic therapy, tapi dia ada time frame lah, 6 hours ke 8 hours. Alright, lepas tu kalau dah tu kita boleh buat neuro rehabilitation, sebab patient mesti ada weakness ke, ada apa-apa kan. Education. Okay, belum. Alright, secondary prevention, contoh patient dah settle lah stroke ya, dah okay boleh discharge, kita bagi secondary prevention. Kita bagi antiplatelet therapy, treat risk factor. Okay, therapeutic lifestyle modification. Okay, ni boom, ni kau nak tengok betul-betul ya. Right. CT always kena buat. CT blood test ECG. Boom. Right. So kalau ischemic kita boleh buat boleh consider thrombolysis, tapi kalau tak boleh kita memang mesti kena bagi antiplatelet therapy. Okay, lepas tu kita secure the airway breathing circulation, blah 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 blah. Right. Lepas tu ni. Alright. Treatment for ni kalau kita boleh buat but the goal for ischemic stroke punya treatment is to restore blood flow or to save the brain yang belum ischemic. Okay. Right, kita boleh buat intravenous thrombolysis, intraarterial thrombolysis or endovascular mechanical thrombectomy. Kita tengok dah ni. Right, intravenous thrombolysis yang ni. So basically dia masuk dalam vein, lepas tu dia cuba thrombolyze. Right, dia pakai catheter, tak tahu macam mana dia buat. Right, ni dia kena given as bolus followed by okay, recommended within 4.5 hours of onset of ischemic stroke. Okay, so 4 jam setengah. Kalau based on history lah, kalau okay, kau bila kau start rasa sakit ni, kau start sakit ni pada pukul 7 tadi. Okay, 7 sekarang masih 9, dah 2 jam, still boleh bagi intravenous. Okay, lepas tu kalau macam lambat kan, more than 4.5 tapi less than 6 hours, kita boleh bagi intraarterial. Tadi intravenous, ni intraarterial. Boom. Kalau tak boleh juga, kalau more than 6 hours tapi less than 8 hours, kita boleh buat endovascular mechanical thrombectomy. Okay. Alright. Ni acute stroke management, blood pressure. Ni just kita cuba maximize lah, ataupun nak cuba optimize anything yang patient ada. Kalau blood glucose tinggi sangat, kita settle. Blood pressure tinggi sangat, kita settle. Infection, syphilis ke apa, kita settle. Increase ICP, kita settle semua ni. Okay. Alright. Ni basically dia cuba cakap lah, kalau airway kita bagi oksigen. Okay, blood pressure tak settle, kita treat, bagi labetalol infusion. Captopril. Blood glucose kita treat hypoglycemia. Nutrition kita perform water swallow test. I don't know what's that. Infection, fever. Okay ni. Alright. Treatment for hemorrhagic. Tadi ischemic, ni hemorrhagic. Basically sama, intracranial pressure control, blood pressure control, seizure control, treat any symptom. Okay. Blood pressure control. But most common of hemorrhagic is hypertension kan. So kita settlekan dia punya blood pressure. Kalau ni tinggi sangat ni, aggressive. Kalau ni tinggi sangat, ni hypertensive crisis lah ni. But severe hypertension is systolic more than 180 kan. So ni dah banyak lah ni. So kita kena aggressive sikit. Okay. Kalau okay, kalau banyak ni labetalol ni. Okay, kalau cuba ingat boleh. Okay, kita ICP tu kita kasih settle. Kita boleh bagi drainage, kita boleh bagi mannitol, iaitu diuretics. Kita boleh bagi semua ni whatever. Right. Seizure control kalau patient ada seizure tapi most patient ada seizure, majority ada seizure. So kita kasih anti-epileptic drug, phenytoin ke apa ke. Okay. Prevention, primary prevention is kita prevent the incidence of stroke, increase awareness, promoting a healthy lifestyle. Secondary is patient kalau dah ada dia dah ada penyakit, cuma just nak prevent from stroke lah. Ni sebelum dapat penyakit ni, kalau dah dapat penyakit tapi nak prevent stroke. Ni kita kasih anti-platelet therapy memang kena bagi, tapi tak tahu how long, lifelong ke ataupun few month ke 1 year, I don't know. Kita kalau patient tu ada high blood pressure, kita settle ni okay. That's it. Ada soalan boys? Boys.
Beres lah, beres.
Beres?
Alright. Mantap, sorry saya lambat sikit.
Alright.
Okay,
Tapi yang penting bagi aku yang
uh.
ischemia punya features kan, macam anterior punya feature, medial cerebral features kan.
Tu penting lah kena tahu. But kalau kita pergi CT ke apa kan, mesti kita kena ada provisional
So
anterior.
kena expect kan. Mantap.
So basically kita tahu lah the supply ni. Blood supply anatomy ni memang kau kena hafal lah memang ni anatomy dia.
Alright.
Boom.
Mantap.
Top.
PUBG lah, PUBG.
Alright. Alright.
Ya nanti, kalau start 10.30 11 tu.
Boleh je.
Boleh.
Okay. Sebab ingat nak pergi jumpa Aizil je.
Oh, okay.
Alright. Bye-bye.
Bye.
Alright, bye-bye.
Kita
Okay.
Yo.
Sekejap.